95 times out of 100, you're going to be okay. So the absolute risk is still only about 5 or 7 in 100. The problem is the relative risk. I've just now exposed your wife, in this case to make it personal, to 5 times or 7 times the risk of that first procedure. So again, it's one of those things where one has to judge risk and benefit. So if the benefit, even though for the flutter ablation, has been less because you're now on a medicine still, but nonetheless the risk is low. If we're going to now do an ablation for atrial fibrillation where the risk is higher, well, the benefit has to be higher. In other words, you should be thinking about doing it if, let's say, the drugs are failing or you're having to go to more powerful medications. Again, a personal decision and really something that you just have to discuss directly and make a decision on a patient-by-patient basis. So you're correct, though, to get at it, that unfortunately, oftentimes atrial fibrillation is a progressive disease, and it may be that in the future, a left-sided ablation where there's going to be some additional risk associated with higher risk than for the ablation on the right side, that will have to be addressed, and go through that carefully and make a decision.
So if we get to the point where we're in an ablation on the left side and it's corrected, is that it, or does it go further?
So God knows I would give anything for a crystal ball. You know what I'm saying? I would have loved to have one of those things. Why don't they hand those out at med school, right? I mean, really? So if I could guarantee 100% success with 0% complication, hell, I would have lined up all my patients with atrial fibrillation straight away. The problem is you can't do any of those things. Particularly success, it's never 100%. It's clearly less, depending on the patient's individual conditions. I try my best. I've been doing it for a long time, but there's no question that in anybody's hands, there's always complications and there's always risk associated with any type of invasive procedure. So again, it's one of those things that really has to be decided on a case-by-case basis and really sort of discussing the pros and cons of all strategies, and depends a lot on associated conditions.
Are these the two areas of the heart that only cause AFib?
Great question. So the question is, where does the atrial fibrillation occur? And so remember how I spoke to you about how paroxysmal atrial fibrillation, where the AFib comes and goes, we're much better at. And that those patients who have what we call persistent atrial fibrillation, where the atrial fibrillation comes and stays, and they might need a cardioversion, we're a little less good. Well, that's because for patients with paroxysmal atrial fibrillation, generally that focus, or the multiple foci, the multiple sort of hot spots, as it were, are within the pulmonary veins, those veins that are bringing blood back from the lungs. In those patients with persistent atrial fibrillation, where the AFib comes and stays, well, that works about half the time. The other half of the time, it's a site from outside the pulmonary veins. In other words, think of the Mustangs having escaped. So you have a wild Mustang running about, or multiple Mustangs in the heart or the ranch itself. In that case, then the ablation's a little bit more difficult, more time-consuming. The longer procedure is, the more the risk, the less the chance for success. But nonetheless, it is something that we in fact do. If I had to sort of put our numbers out there, I would say that the majority of our patients are actually patients who've had ablations at other places and then have come to us either because of referral or whatever the case may be.